the summary there is that there's a lot of options, and there's probably not one absolute best option for any patient, but we look at sidedness as an option. So what we're talking about there is, where does the primary tumor originate? Does it arise on the right side of the colon, which is largely the cecum up to the hepatic flexure? Transverse colon gets a little murky. That's a transition portion of the large bowel. And then we talk about the descending colon through the rectum being left-sided. And so data is pretty consistent, although not always prospective, that suggests that patients who have right-sided tumors probably don't do well with an EGFR antibody-containing regimen. And so that's something that most of us in the field are incorporating into our routine practice. So if we see a patient who comes in with a right-sided tumor, probably regardless of what their molecular profile is, we've been using RAS as a way to try to stratify an appropriate antibody therapy for patients for some number of years now, but sidedness also has to come into that decision. So you look at the molecular features of RAS, NRAS, KRAS, and RAF profile, and then also I think the sidedness of the tumor. So that helps us direct between an EGFR antibody and an anti-VEGF antibody. And then really which chemotherapy platform we couple that with comes down to patients' preferences, providers' comfort level, and toxicities, really. If you have a patient who is going to do better with a regimen that spares neuropathy, you're going to usually use an irinotecan-containing regimen, FOLFIRI. If a patient has more GI toxicities to begin with, maybe they've had surgeries, maybe they're an inflammatory bowel patient, you don't want to run the risk of diarrhea and enteritis, you might stray more towards oxaliplatin-based therapy. We certainly know from population-based usage that oxaliplatin-based therapies are more commonly used in North America. Probably 75% of patients get that in the frontline setting.